Good morning. I'm happy today to speak about chronic kidney disease. Why? Because this is one of very important topics in nephrology, and it is usually associated with many comorbidities. This is why you will find many YouTube videos for me to speak about the chronic kidney disease, and usually I focus on preventive aspects, how to retard progression of chronic kidney disease. Let us start with the case. So this is a 65-year-old male patient, diabetic, type 2 diabetes for 15 years, hypertensive, blood pressure is 160/100, obese, body mass index 38 kilogram per square meter, creatinine of 2 milligram per deciliter, and estimated GFR is 35 milliliter per minute. Albumin creatinine ratio is 500 milligram per gram creatinine. Hemoglobin 9 gram per deciliter. He is a smoker and suffering from sleep disorders. So this is the history of the patient. For this case, we have three questions. What is the stage of CKD? Which formula is preferred to estimate GFR? And the third and the last one, what are the risk factors for chronic kidney disease progression that this senior gentleman patient has? So I'm going to discuss the issue of chronic kidney disease, and at the end of the presentation we will answer these questions. Let us start with definition. Chronic kidney disease is by default chronic, and it is progressive, but the base of progression is completely different from acute kidney injury. And the most important point in the definition is persistent derangement of kidney function more than 3 months. So CKD is defined as abnormalities of kidney structure or function present for more than 3 months with implications for health. These may include the following: markers of kidney damage like albuminuria, and I'm going to explain in a minute; sediment abnormalities like hematuria, and should be persistent for 3 months; electrolyte abnormalities that are explained by kidney dysfunction; abnormalities through histology; structure abnormality by imaging like ultrasound; history of kidney transplantation; and or GFR less than 60 milliliter per minute. So to define chronic kidney disease, we should look at GFR and or urine analysis, radiology, ATC. Don't forget that we need abnormalities to be more persistent for more than 3 months. So the demarcation between acute and chronic is 3 months. Look here carefully. We have this slide appears as complicated, but we will take it one by one, step by step. We have here degrees of albuminuria. So we have A1, A2 that was known before as microalbuminuria, but we don't like this term of microalbuminuria. So it is replaced by A2 and then A3. A1 means normal albuminuria to mildly increased. A2 means moderate increased albuminuria. A3 means severely increased or with nephrotic syndrome patients. What is the value in the urine to say A1, A2, A3? Because it is very important and can be put in MCQ questions. So here, if albuminuria is between 30 milligram albumin per gram creatinine or less than 3 milligram albumin per millimole creatinine in the urine sample, it is known as A1. A2, if in this range between 330 to 300 or 3 to 30, and according to what we use. A3 above 300 milligram per gram creatinine or above 30 milligram per millimole creatinine, and also nephrotic syndrome here. Then look at GFR. Here's GFR is estimated. How to assess glomerular filtration rate is either by estimation from calculations from formula or to be measured. Measurement of GFR is the most famous and practical is creatinine clearance. And we may monitor and measure GFR by more advanced like isotope clearance or inulin clearance, and these isotope clearance and inulin clearance are used in research. So we can measure by exogenous like inulin, isotope, or endogenous like creatinine clearance. But creatinine clearance depends upon the 24-hour urine collection. Here we can estimate. What is meant by estimation is by applying a formula. The recommended formula by the nephrology recommendations KDIGO guidelines in 2012 is the use of CKD epidemiology equation. So we have estimated GFR above 90, it is normal. And 60 to 90, it's above 60. So if we have GFR in this range from 60 to above, and albuminuria is in A1 and nothing other than this, no hematuria, no structural damage, so this is a normal person. This person is not a person with chronic kidney disease. So this is why the corner is green. To say stage 1 chronic kidney disease, GFR is above or equal 90, but we should have abnormalities either in albuminuria or hematuria or electrolytes or histology. So this is, if we are here, this is stage 1. Between 60 to 90 milliliter per minute estimated GFR is stage 2. Stage 3 is divided into two parts, 3A and 3B. So from 60 to 45, it is 3A, irrespective to the level of albuminuria. So here it is not green color. From 45 to 30, less than 45 to 30, it is 3B. Stage 4, it is severe decreased kidney function. It is stage 4 CKD. And the GFR estimated is between 15 to 30. And kidney failure stage or stage 5 or severe CKD or very low GFR, it is less than 15 milliliter per minute. So if we apply the definition, if we have persistent low GFR less than 60 for more than 3 months, irrespective to the parameters denoting kidney damage, we are in stages, different stages of CKD according to the level of GFR. If we are above 60, we should evaluate other parameters denoting kidney damage, and these parameters should be persistent for more than 3 months. If we are here, this is stage 1. If we are here, stage 2. So what is left is the secrets of colors. We have green color, and I explained green color means we are normal. What is the yellow, orange, and red? These are different heat map colors denoting the CKD, and the difference in color reflects the increased severity. So severity increased, the risk for comorbidities increased with darkening of the color. So here, what are the comorbidities that may be increased by darkening of the color are progression of CKD. So the more the darker the color, the more the rapid the progression of CKD. Secondly, increase the risk of development of acute kidney injury on top of chronic kidney disease. Thirdly, cardiovascular diseases. And fourthly, mortality increases with increased color, the darkness of the color. So this is a heat map. Green is fine, very good, healthy, and yellow is disease, and the red color denotes severity of the situation and the severe risk for occurrence of comorbidities. So this is the definition of chronic kidney disease. Everything is precise. If we go from a stage to higher stage, this means that we are progressing. By the way, chronic kidney disease is by default is progressive. But if we succeed to slow the progression, we consider this as a success. What are the causes of chronic kidney disease? according to the epidemiology and according to the data, United States Renal Data System, the current report shows that diabetes mellitus, second type 2 diabetes, is the leading cause of chronic kidney disease, followed by hypertension, then glomerulonephritis, polycystic kidney disease, and a big category of unknown causes are here in this corner. Unknown causes may be due to infections, abusing drugs, etc. This is a very nice list for the causes, including examples of systemic diseases affecting the kidney, or affection of the kidney by itself. So the kidney is primarily affected. So here the disease may affect the glomeruli, tubulointerstitial diseases, vascular diseases, cystic or congenital, and disease affecting the transplant kidney. So glomerular diseases may be due to diabetes, so this is a systemic disease, autoimmune diseases like lupus nephritis, systemic infections, drugs, neoplasm. Here, these are the primary kidney diseases. It affects the kidney as solely affected or primarily affected, like diffuse, focal, or crescentic proliferative glomerulonephritis. Focal means less than 50% affection of the glomeruli. Segmental means part of the glomerulus is affected, either by proliferative process or glomerulosclerosis process. Membranous means the thickening of the basement membrane. Minimal change disease means that light microscope shows no abnormalities. Tubulointerstitial disease may be due to systemic causes like systemic infections, autoimmune diseases, sarcoidosis, drugs, urate, environmental toxins like heavy metals, neoplasms like myeloma, or primarily affecting the kidney like urinary tract infections, stones, obstructions. Vascular diseases may be systemic diseases like decreased perfusion due to heart failure, liver diseases, renal artery diseases, atherosclerosis, hypertension, ischemic cholesterol emboli, vasculitis, thrombotic microangiopathy, systemic sclerosis. And the vascular disease may affect kidney primarily, may be ANCA-associated vasculitis, fibromuscular dysplasia of renal vessels, cystic and congenital disease, including polycystic kidney disease. Here in the systemic diseases, because polycystic kidney may be associated with liver cysts and other organ cystic diseases, Fabry diseases, stenosis, all these are congenital diseases. Renal dysplastic, medullary cystic disease are diseases exclusively affecting the kidney. Diseases affecting transplanted kidney may be due to the recurrence of the systemic disease, the recurrence of original kidney disease, or affection by diabetes, Fabry's disease. Here in the primary disease, chronic rejection, calcium inhibitor toxicity, and so this is restricted to the transplanted kidney. So causes of chronic kidney disease are enormous, including diseases that may affect glomeruli, tubulointerstitium, vasculars, cystic kidney disease, or transplanted kidney. So you can, this is just for simplicity, you can say systemic disease affecting kidney or primary disease affecting the kidney alone. Or the simplest way is to say the etiology according to the prevalence, diabetes, type 2 diabetes, hypertension, glomerulonephritis, and polycystic kidney disease. Before discussing clinical manifestations of renal failure or chronic kidney disease, I would like to start with this quotation just to show the importance of our healthy kidneys. Bones can break, muscles can atrophy, glands can loaf about, and even brain can sleep without immediate danger to survival. But what is the situation when kidneys fail? Neither bone, muscle, gland, nor brain could carry on. This means that the kidney is essential for the hemostasis of the body. We have symptoms and signs. For symptoms, you may find difficult sleeping, nocturia, headache, restless leg syndrome, metallic taste, shortness of breath on exertion or at rest, paroxysmal nocturnal dyspnea, fatigue, the muscle cramps, seizures, lack or loss of appetite, abdominal pain, nausea, vomiting, weight loss, itchy, pruritus on the trunk, and worse at night. The signs may be altered respiration, like cosmo respiration, they mean acidotic, deep in rate and depth, and high rate and high depth, and kinestotic respiration, red eyes due to calcium deposition, muscle weakness, oral lesions like gingival bleeding, petechiae, infections, pericardial rub, pulmonary and peripheral edema, skin changes like scratch, dryness, pallor, other hyperpigmentation, tremors, flutter, uremic frost. I'm now almost approximate 30 years working in nephrology. I didn't see uremic frost, so it was in the past. But as you see in this table, the all body symptoms can be seen in chronic renal failure, and the same all signs can be encountered. This is why I like this drawing from Professor Sobh's book. The clinical features of uremic syndrome or chronic renal failure can be represented by this drawing. So it affects human body from the crown to heel. Just look at any organ and you can expect any symptoms or any sign, and you can find it in uremia. So renal failure or chronic renal failure is a big imitator for many diseases and to be considered. This is why we order serum creatinine and evaluate the kidney in the basic evaluation. The most important points that I always stress upon is the studying risk factors for chronic kidney disease, even if they are non-modifiable. Why? Because if they are even non-modifiable, we should take care of the modifiable risk factors seriously in these patients. So risk factors are a state that increase the problem, but not necessarily that the problem will occur. So even if there is no evidence-based recommendation based on a randomized controlled study, it's better to respect risk factors. What are the risk factors? I'm going to start with the non-modifiable risk factors. To be put in mind, low birth weight. So low birth weight is considered among nephrologists as a risk factor for future occurrence of chronic kidney disease. To the extent some authorities consider low birth weight is a contraindication for live kidney donation later on, even if the person enjoys normal kidney functions. So it's better to record and to have the recording of the body weight at birth. Second, non-modifiable risk factor, previous history of childhood kidney disease, because this is a cohort study, included 1.5 million persons, and this is a population-based historical cohort study, documented that history of childhood kidney disease is an independent risk factor for occurrence of end-stage kidney disease later on in the life. So we should ask about previous history of kidney diseases like nephrotic syndrome in childhood, pyelonephritis in childhood, etc. Previous occurrence of acute renal failure or acute kidney injury, even if acute kidney injury is recovered. Why? Because the previous history of acute kidney injury was associated with increased risk of future chronic kidney disease and subsequent proteinuria. We should ask about these in our evaluation, the history of AKI when we evaluate any patients in nephrology ward. Aging. Old age is considered a risk factor for chronic kidney disease. Why? Because our kidneys age. What's meant by aging kidney? That you can find here, this is the young kidney and this is the old kidney. You can find a great difference. A great difference in the macroscopic and the microscopic reduction of the mass, weight, length, and the parenchyma. And if we examine the kidney by microscope, you will find chronic changes in the glomeruli, interstitium, and the blood vessels and the tubules. So this means that the kidney is aging. What is the consequence of the aging kidney is we expect functional changes in the elderly person. functions, the reduction of GFR, and more importantly, the reduction of kidney tubular functions. If I ask you what is more smart, glomerular function or tubular function, the answer is tubular function. One of the tubular function is the capacity of the kidney or capability of the kidney to concentrate and to dilute urine. The both concentration and dilution of urine functions are impaired in elderly person. This is why these persons are more prone to the dehydration, because they cannot concentrate urine maximally. So we should avoid and combat and prevent dehydration. And at the same moment, they are not able to tolerate volume because they cannot dilute urine maximally. So they are more prone to volume overload, hyponatremia, hypertension. So we should be careful, very careful about giving fluid therapy for elderly patients in the hospital. So we should avoid dehydration, and at the same moment we shouldn't overload these patients. So I mentioned low birth weight, a previous history of childhood kidney disease, acute kidney injury, aging, and then gender. What's your expectation? Is chronic kidney disease more evident in females or in males? Let us to see what's meant by sexual dimorphism. Dimorphism, this means that we have the two phenomena. In females, chronic kidney disease is more frequent than males, especially if we think of stages 3 and 4, but progression of chronic kidney disease is more frequent in males. What's meant by progression is toward the need of dialysis and transplantation is more common in males than females. So chronic kidney disease is more prevalent in female, but the rate of progression is more fast in males. This is why the majority of dialyzed and transplanted patients are males. This may be the two difference between male and female in all these axes. The capacity, the ability to withstand oxidative stress is better in females. Hormones, it may be testosterone is aggressive and a bad hormone, maybe. So all the factors that I mentioned up to this moment are non-modifiable risk factors, including the low birth weight, previous history of kidney disease, previous history of acute kidney injury, the gender, and the age. Let us go to the modifiable risk factors. And one of very important risk factors in the etiology of chronic kidney disease is hypertension. Although some authors don't agree about hypertension as the cause of chronic kidney disease, and there are solid criteria should be respected to say hypertension is the cause, that hypertension is persistent for many years before diagnosing CKD. But chronic kidney disease can cause hypertension. Irrespective to all this hassle, hypertension is an important risk factor that increase many factors and many axes, including hormones, oxidative stress, that increase progression of CKD. This is why we should be able to measure it properly, following the recommendations, and to treat the hypertension. And our target in chronic kidney disease is to reduce hypertension blood pressure toward 130 over 80 millimeter mercury. If there is proteinuria, the drug of choice is angiotensin converting enzyme inhibitor or angiotensin receptor blocker. The European, if there is no proteinuria, we start with the first line drugs, either by using ACE inhibitors or ARB or calcium channel blockers or diuretics. So this is the first line of treatment. Beta blocker is not among the first line of antihypertensive drugs, and it is reserved for compelling indications like heart failure, ischemic heart disease, and tachycardia and thyrotoxicosis. Here in the European guidelines, they like to start with combination therapy, either ACE inhibitor plus either calcium channel blocker or diuretics, and then to add the second agent, third agent. Lastly, we add spironolactone to target aldosterone. Regarding diuretics, if estimated GFR is above 30, we use thiazide. If it's less than 30 milliliter per minute, we shift it to loop diuretics. So the target of blood pressure control is 130/80, and the drug of choice are either ACE inhibitor, and the target of ACE inhibitor or ARB are the first drug of choice, especially if the patient has proteinuria. And then we have other drugs, and then if there is no proteinuria, we can individualize our management according to the patient preference. So if the patient is edematous, we can start with diuretics. So this is regarding hypertension. Regarding diabetes, type 2 diabetes, you can find a lot of YouTubes you can go through, but one of the most important statement that you will find within the final guidelines that I'm expecting to find the final form of the guidelines to be released within this year. The most important statement is for treating diabetic kidney disease to retard the progression of kidney disease is to follow holistic approach, multi risk factor modification, comprehensive strategy. So we are not restricted for treating diabetes and hyperglycemia. Yes, glycemic control is very crucial, and nowadays there is increased preference to use sodium glucose cotransporter 2 inhibitors as anti-diabetic drugs, especially if estimated GFR above 30, because they are not being accepted to estimated GFR less than 30. And the target glycemia control is according to the stage of CKD. If you are in the early stages, like stage 1 and 2, it is better to intensively control glycemia. A1C, glycosylated A1C, to be less than 7%. After that, in stage 3, 4, and 5, we should be cautious about hypoglycemia, and we exert more relaxed glycemic control according to the risk of glycemia or occurrence of hypoglycemia, because hypoglycemia may be fatal. RAS blockade in the presence of proteinuria, blood pressure control is mandatory, lipid abnormalities to be treated, lifestyle, sedentary life, obesity, and physical inactivity should be targeted and treated and corrected. Smoking should be discontinued, because smoking is considered, and I'm going to mention it in one of the next slides, is a kidney poison. Nutrition, how to eat and what to eat. Aspirin to prevent cardiovascular disease. So this is the cardio-kidney risk factor management in diabetic patient. So the recommendation here, as you see, with sufficient evidence, the KDIGO recommend that treatment with an angiotensin converting enzyme inhibitor, or don't say or, because we don't combine them. So ACE inhibitor or angiotensin 2 receptor blocker be initiated in patients with diabetes, hypertension, and albuminuria, and that these medications should be titrated to the highest approved dose that is well tolerated. And to put in mind, when we use ACE inhibitor or ARBs, we should monitor kidney function and potassium within 2 weeks. And if there is an rise, we repeat the measurement until we see the plateau, because we don't like serum creatinine to exceed 30% of the baseline to avoid the nephrotoxicity of this class of drugs. The more important and the more stressing points, I like this, to work on the population to prevent diabetes, because if we can prevent the diabetes, this is a primary prevention of diabetic kidney disease. So if you follow American Diabetes Association calculator, you just go to Google and write the calculator, you'll find the age, gender, you just fill in the space. So if you select these choices, the risk is 8 points, and then you will have the advice what to do. So it's better to follow preventive strategies than treatment strategies. Yes, we will treat, but the best is to prevent. So again, this is the second modifiable risk factors, hypertension and diabetes. The third, and usually neglected, is metabolic acidosis. We don't like metabolic acidosis because metabolic acidosis increases the risk of progression of chronic kidney disease through many mechanisms, including maladaptive process, hormonal, endothelin, etc. And as you see here, with overt acidosis means serum bicarbonate is less than normal, or even if the sodium bicarbonate is normal in the blood, but in the low normal range, this means that the kidney exert its effects to keep bicarb within normal through increasing ammonia generation. Excessive ammonia generation is toxic to the kidney, increases CKD progression. This is why we like serum bicarbonate to be between 24 to 26 milliequivalent per liter. This is the best level. This is a target that we would like to see either by diet or by using sodium bicarbonate. This is what we have. Dietary management, and I'm going to discuss diet within the diet sector, or to use sodium bicarbonate to reach rich target between 24 to 26. In the pipeline, Vivrimir, this is an HCl binder drug, may be proven, and we are waiting further studies, and it is binder to HCl, increasing bicarbonate without adding sodium. So a lot of studies are ongoing, and I think it will be approved by the end of this year. Hyperuricemia. Hyperuricemia is a modifiable risk factor that is associated with increased chronic kidney disease progression. What to do is to follow lifestyle modification, diet, exercise, and if we believe in hyperuricemic drug, because the evidence is still lacking, especially after the publication of one of the very recent studies showed no benefit, so the evidence is debated. But if there is hyperuricemia, we may use allopurinol in a small dose, but to evaluate the occurrence of side effects and to increase the dose step by step until we reach the maximum compatible with GFR. One of the very important risk factors, so by this way I started the modifiable risk factors, hypertension, followed by diabetes, and then acidosis, and hyperuricemia, and then one of the best risk factor to be modified is to avoid inappropriate prescription of medications, to respect the kidney, because all drugs, and usually every day we are asked by patients and by colleagues, what is the nephrotoxic drug? All drugs are potentially nephrotoxic. So we should avoid any drug prescription except if it is indicated. In children, you'll find here inappropriate prescription in chronic kidney disease with the use of non-steroidal proton pump inhibitors and other nephrotoxic drugs and antibiotics. Regarding this is I'm going to select some examples. Proton pump inhibitors, drugs that inhibit HCl. This, so it is proton pump inhibitors. So this is the list of adverse events of proton pump inhibitors, including non-kidney events like atrophic gastritis, vitamin B12 malabsorption, cardiovascular disease, Clostridium difficile infection, community acquired pneumonia, dementia, gastric cancer, osteoporotic fracture. So all these are non-kidney events. Adverse kidney outcome, including electrolyte disturbance, hypomagnesemia, especially for patients using diuretics or having malabsorption, acute kidney injury, acute interstitial nephritis, incident chronic kidney disease, and kidney failure and the progression of chronic kidney disease. All these are side effects of this drug. Cause of death associated with proton pump inhibitor use, all-cause mortality is increased, death due to cardiovascular disease, death due to chronic kidney disease, death due to upper gastrointestinal cancer. And here I want to say that you can find even cocktail of infections rather than these. And more importantly, there are some drug interactions that is usually neglected. So this is regarding the adverse effects. So what to do? What is the rationale of using them? If there is no indication for proton pump inhibitor use, stop them, please. If unknown indication, lower the dose or stop them. BPI, mild and moderate esophagitis or GERD, gastroesophageal reflux disease, treated for just 4 to 8 weeks, and then lower or stop the drugs according to the patient's symptoms. Peptic ulcer disease from non-steroidal or Helicobacter pylori treated patients, treat for 2 to 12 weeks, not forever. In the presence of upper gastrointestinal symptoms, asymptomatic ICU stress ulcers, prophylaxis, and complications. So to be left here and complications just for 2 weeks, short duration, and then stop. Severe esophagitis, Barrett's esophagus, history of bleeding, chronic NSAID users with bleeding risk, continue BPI. In case of adverse event, deprescription trial in consultation with a gastroenterologist may be considered. And then if we decided to stop BPI, we should monitor the patient because we may need them for a short period of time. So providers should limit dose and duration to minimum necessary, and consideration should be given to monitor estimated GFR and serum magnesium level, especially in diuretics users, especially important in patients using concomitant diuretics. And for BPI, it is one word, deprescription. Deprescription means either to stop them or to lower them or to use them in intermittent fashion. We use them in transplanted patients because in transplanted patients they receive steroid and other drugs. So we give them for 1 week in a month, and the rest of the month H2 receptor blockers. Second, examples of bad drugs that we don't like at all. And we always discuss with orthopedic doctors to avoid the abusing non-steroidal because they do cocktail of different NSAID. We can use NSAID in a very small dose, provided that we monitor our patient in chronic kidney disease. So the guiding points for safe, it is not absolute safe, but for a more conservative approach. Always monitor creatinine, electrolytes, because there is a risk of hyperkalemia and hyponatremia, weights and blood pressure before and after non-steroidal, and other guidelines, other advices here. This is an important space NSAID to 2 hours after aspirin, because there is a theoretical risk of antagonizing aspirin action by COX-1 inhibition. Avoid NSAID if patients are in stress, acute illness, hypovolemia, fluctuating kidney function, concomitant introduction or a change in dosages of diuretics and RAS blockers, patients with uncontrolled hypertension and volume overload. Always use the lowest effective dose for the shortest possible duration. Regularly reassess the need for ongoing NSAID use. So it's better to avoid and to educate our patients and other specialties toward the minimum use of these drugs. So NSAID can be used cautiously in chronic kidney disease, especially for short courses and potentially for longer duration after discussing trade-off with the patients. What's about antibiotics? Today I'm going to present for you strange data. Antibiotics, yes, we know antibiotics may be associated with hypersensitivity, raising resistant strains of organisms, but what is this? Oral antibiotics exposure causes kidney stone disease and associated with kidney stone disease according to this Jessen report, and this is another American Journal of Kidney Disease report. Antibiotic use, especially if it's using for more than 28 days in some use. So why antibiotics are associated with kidney stones? I'm going to explain them after saying a few words about gut microbiome. We are living with a heroic number of gut microbiome. To be healthy without chronic kidney disease, the gut microbiome should be healthy. And the use of antibiotics are associated with disturbance of gut microbiome. And here why antibiotic use increases stones, because some of healthy and important gut microflora is the oxalobiome, which are oxalate degrading gut microbiome. Antibiotics disrupt them, so oxalate becomes feasible for absorption. So if we destroy the healthy gut microbiome, there is increased absorption of oxalate with subsequent occurrence of urinary stones. So oxalobiome is disturbed. Gut microbiome is unhealthy in chronic kidney disease, so there is a bidirectional relationship. Chronic kidney disease is associated with abnormalities of gut microbiome. This is known as dysbiosis. And abnormalities of gut microbiome leads to release of uremic toxin. And here just a few words about how to keep the healthy gut microbiome is by encouraging vaginal delivery, stopping abusing a cesarean section. Number two, proper time, sufficient time of lactation, avoiding the use of antibiotics. All these are simple advices that can leave the healthy gut microbiome. And you can find on the YouTube this presentation by Professor Antoine Berberi about subconscious mind and gut microbiome, and there is a relation to our state of health. So again, I mentioned in this modifiable risk factors sector, hypertension, diabetes, use of drugs, antibiotics, and I mentioned some of them, hyperuricemia, metabolic acidosis. And now I'm going to highlight about the herbal remedies and vitamin supplements. So this is one of the slides showing that herbal remedies are very bad and usually adulterated. Adulterated means some toxins, some added to the herbal remedies. And for your information, usually non-steroidal diuretics, laxatives are added as adulteration to the herbal remedies. This is why herbal remedies are associated with side effects. Some Chinese herbal remedies are full of ochratoxin that lead to interstitial fibrosis and urothelial malignancy. So if I want to say one word about herbal remedies, stop them. Just say no. Sleep disorders. We should learn how to sleep, healthy sleep style, because inappropriate quantity and quality of sleep, so if we sleep less than 5 hours or above 8 hours, or we sleep fragmented sleep, all these factors are associated with increased CKD progression, and may be due to increased sympathetic activity. The toxins, toxicology. Here, again and again, supplement. The Food and Drugs Administration regulates the use of vitamins, mineral, herbs, or botanical as dietary supplements. They may, in fact, contain actual pharmaceuticals or nothing of value and have significant toxic potential. Nephrotoxic syndromes due to Chinese herbal medicine, including acute kidney injury, progressive kidney disease, nephrolithiasis, Fanconi, rhabdomyolysis, myoglobinuric kidney injury, urothelial malignancy. Soil contamination with heavy metals lead to bioaccumulation, herbal and medicinal plants, and potential toxicity. So we should be careful about that. Smoking. Smoking is the kidney poison. Disturb all the components of the kidney, glomeruli, tubules, blood vessels. So just to say, we say to the patients in the outpatient clinic, if you want to keep your kidney healthy, stop smoking. And this is a very strange. Second-hand smoking, passive smokers are associated with increased risk of chronic kidney disease. What about obesity, nutritional, and exercise? If we don't do exercise, this will increase the risk of CKD. So we should encourage exercise for the patient, for the normal persons. And if the patient has chronic kidney disease, we encourage ambulation, even walking, according to the capacity of the patients. We should combat obesity because obesity is linked either directly or indirectly with CKD. And you can find this is video is dedicated for nutritional approach to retard the progression of CKD. Why diets increase the risk of chronic kidney disease progression? Potential mechanisms for diet-related kidney injury may include hyperfiltration induced by heavy proteins, oxidative stress, inflammation. So we have inflaming diet like heavy proteins, and acid-induced kidney injury. This is why we stress in the World Kidney Day activities to measure waist circumference to combat obesity. And we should combat obesity because obesity are associated with hormonal, neuronal, and kidney dysfunction axis. And even obesity can compress lobe of Henle, increase sodium reabsorption here, and this will lead to disturbance of tubulo-glomerular feedback leading to hyperfiltration. So we should be educated against obesity by reducing calories in general. We should speak to general population to reduce calories and to do exercise. Regarding red meat, is it friend or foe, good or bad for patients with chronic kidney disease? The only benefit is the presence, the inclusion of essential amino acid. But as you see, the balance is tipped toward the harm because a lot of salt, phosphate, and acid load. So we advise against red meat for these patients. High protein diet is toxic to the kidney and associated with hyperfiltration. The same high carbohydrate diet. So high carbohydrate density. This means that if carbohydrate constitutes more than 70% of total calories, this is one of risk factors for chronic kidney disease. So we should be aware about that and to reduce carbohydrate less than 60% of the total calories. DASH diet, and I like this slide, and I like all general population, not all of you, all general population to know what's meant by DASH, diet approach to stop hypertension. It includes these items. So saturated fat, percent of energy taken from saturated fat, if it is less than 6%, this means we are in the target. If it is less than 11%, this means we are in the intermediate target. Total fat, percent of energy taken from total fat, less than 27%. So fat constitutes less than 27% of total calories. It is within the target. 32%, it is half target. Fibers, if it's above 14.8 gram per 1,000 kilocalories, this means we are in the target. If it is here above 9.5 gram per 1,000 calories, this means that we are in the intermediate calorie target. Potassium to be high in target, lower in half target. Sodium to be low because high sodium is bad for health, for kidney. So if we achieve the target, for each point we take 1 point. If we achieve half target, intermediate target, half point. So we need to have more than 5 total points to assure nephroprotection. Because DASH diet approach to stop hypertension helps in controlling blood pressure, uric acid, stones, and others, with subsequent improving the kidney and the cardiovascular system. We should encourage plans, especially for general population. Don't wait until we have advanced chronic kidney disease to be afraid of potassium-containing diets. So this is why we encourage the intake of vegetables even for patients with early stages of CKD, because the use of vegetables improve intestinal transit time, including fibers and alkaline, decrease phosphate, increase magnesium. All these are friends for the kidney. And this is the advice for our patient in the early stages of CKD, is to encourage fruits and vegetables. And if they are treated with drugs that may lead to hyperkalemia, we monitor serum potassium. So a lot of benefits: decreasing blood pressure, preventing metabolic diseases, delaying CKD progression, and decreased mortality. The only harm is increased potassium that we may measure. So vegetarian diets are associated with low fat, low carbohydrate, high fibers, low protein, low phosphorus, low acid load, low salt. And all these composition points are beneficial to the intestinal gut microbiome, to pancreas, heart, and kidney. So this is should be. Again, plant-based diets are associated with more kidney health and the reduced CKD progression. This is how to be sure that the patient is compliant with the advice by measuring urinary potassium excretion. So the higher urinary potassium means that the patient is compliant in fruits and vegetables, the lower the risk of progression of CKD. And this is how to know, and I'm not going to bother you by this point. Regarding acid diet, we encourage alkaline diet to retard the progression and to correct acidosis. If we start early with reducing hard processed cheese, meats, egg yolk, and concentrate on the not wine, concentrate in fruits and vegetables, spinach, raisins, all these are base producing alkaline. Here this is the acid load is by negative, and here it is positive. We should avoid positive potential renal acid load by avoiding all these points. By this way, we even correct sodium bicarbonate in the blood. For the diet control of uric acid, as I mentioned in the hyperuricemia sector, here we should avoid the use of fructose, because fructose at the end of the day increases uric acid. So this is why we don't replace glucose by fructose as sweeteners. Soda. We are against the all the beverages, including even sugary soda or diet soda. Why diet soda is associated with increased risk of end-stage kidney disease may be due to disturbance of gut microbiome, acid load, phosphate, and others. Even if there is no sugar, the soda is harmful. So this is why I bought this video in Arabic to advocate against all these types of drinks. The only safe is to drink water, not high amount. It is to avoid dehydration, the only plain water. So what's about coffee? Because coffee is, this is good news. Coffee with little or no sugar is healthy for the kidney. So we encourage coffee drinking. Coffee is good for health, but without sugar, without smoking. And the only exception in kidney disease is patients with polycystic kidney disease. We advise against coffee in patients with polycystic kidney disease. Why? Because adenosine containing coffee increases cyst growth. So with the exception of polycystic kidney disease, all kidney diseases can have the benefit of coffee consumption without sugar. Regarding stones, we encourage fibers. Here, fruits. The fibers are beneficial to reduce stones. Low salt, because high salt is associated with stone formation. To sum up all risk factors, we have either modifiable or non-modifiable risk factors. Even if the patient has non-modifiable risk factors, we should aggressively address modifiable risk factor in this patient. So risk factors include albuminuria. Do you remember the heat map? The color darken with increasing albuminuria. Even if we are in the stage 1, the red color appears if albuminuria in A3. So albuminuria, hypertension, previous episodes of acute kidney injury, underlying kidney disease like diabetic nephropathy, obesity, hyperlipidemia, smoking, high protein diet, metabolic acidosis, hyperphosphatemia, hyperuricemia, hyperglycemia, elevated urokinase, apolipoprotein 1 alleles in African American, black or native African American race, male sex, older age, here male sex for progression of kidney disease, family history of diabetes, CKD, or end-stage kidney disease. This is why we should ask about family history, not past history alone. Low birth weight, as I mentioned in the beginning. So this is the list. This is a summary of all risk factors that I mentioned. What are the strategies to follow to combat and to mitigate chronic kidney disease? What should we do? We should educate people. And this is one of my writings in Arabic, how to address all diet and other lifestyles to keep the kidney healthy. So the components of chronic kidney disease education include explanation of normal kidney function, blood pressure, laboratory test results and their significance, explanation of specific diseases, conditions, symptoms, and complications of CKD, dietary teaching, diabetes education, facilitating medication knowledge and adherence, and to avoid abusing medications, about vein preservation. This is an advance because if chronic kidney disease progresses, this means that we may need replacement therapy like dialysis or transplantation. I'm not going to speak about dialysis and transplantation in this presentation. So these are therapies to slow progression of CKD, angiotensin converting enzyme inhibitors, or angiotensin receptor antagonist, blood pressure control to less than to around 130/80. So these are of proven benefit. Preliminary evidence for aldosterone receptor antagonist, dietary measures, exercise, weight loss and obesity, smoking cessation, and others. So this is the risk of albuminuria. If you have albuminuria, so this is the if we are here in A1, diagnose and treat the cause, treat comorbid condition. So this is the secret why the definition is important, because it unifies our approach. If we are in the early stages, it's better to address risk factors to reduce progression and to follow healthy lifestyle. If we are here, we may use antihypertensive medications. If we are here, we can expect that the patient is nephrotic, treat nephrotic accordingly. According to the GFR stages, if we are in stage 1, diagnose and treat the cause, treat comorbid condition, evaluate for CKD risk factor, and reduce CKD progression. The same here for stage 2, estimate progression. For stage 3A, adjust medication, dosages, treat hypertension, and here you may start treating anemia in stage 3A. So we evaluate anemia by iron profiling, and if we satisfy iron need, we may add erythropoietin or something like that, erythropoiesis stimulating agents. In stage 5, we need kidney replacement therapy. If we have donor, we go ahead if we are in stage 5 plus clinical manifestations, which because you may find a person in stage 5 for years. So we should follow the trend of these patients and the occurrence of complications. And if we feel that the patient in need of replacement therapy and he has a donor, we go ahead for transplantation. If he has no donor and there is an indication for replacement therapy, we start dialysis. So how to face CKD? So we address everything from individual point to address risk factors, decrease in metabolic syndrome, early detection of CKD, prevention of CKD progression, and if there is end-stage kidney disease, we treat the patient appropriately. You can review transplantation that was released here in March this year. This year, World Kidney Day, the focus of World Kidney Day is kidney health for all, preventing CKD in low and middle income countries and high income countries. And this is a strategy of preventive medicine in nephrology. So primary prevention aim to obviate or minimize the risk of CKD occurrence. So if we prevent diabetes, this is primary prevention of CKD. Secondary prevention, early detection and treating of CKD. Tertiary prevention, prevent the progression of CKD. What are the strategies to be followed for primary prevention? Promote healthy lifestyle choices such as increased physical activity and dietary salt restriction. This is for all population in the country. Influence predisposing behavioral patterns. Smoking cessation is mandatory. Abstinence from alcohol and restrict the use of over-the-counter medications and herbal preparations. Healthy education about CKD and its risk factors. This is what is done in the World Kidney Day. Secondary prevention, screening for risk factors for kidney disease, as well as the presence of CKD. Staged approach to screening. Screen to identify individuals unaware of the presence of hypertension, diabetes, and identify individuals screened for the presence of CKD and appropriate treatment instituted. Third, tertiary prevention, effective control blood pressure to less than 140/90 or 130/80 if there is urine albuminuria exceeding 30 milligram per 24 hours. Effective control of albuminuria and proteinuria, use of angiotensin converting enzyme inhibitors, and after that we can treat the comorbidities like acidosis, anemia, and to offer replacement therapy at the appropriate time. So the World Kidney Day today, this year, kidney health for everyone, everywhere, from prevention to detection and equitable access to care, to bottom line. Let us go again to the case. So 65-year-old male patient, diabetic, and this is the case. What is the stage of CKD here? Estimate GFR at 35. So if we think of estimate GFR between 45 and 30, so it is stage 3B. Albumin creatinine ratio is 500 milligram per gram, so it is A3. So this is CKD is stage 3B, A3, and the patient is anemic. Which formula is preferred to estimate GFR in chronic kidney disease, especially within normal range? We use CKD epidemiology equation because it is precise with normal GFR. If we use MDRD equation and the GFR is above 60, we cannot say 70, 80, we just say above 60. But with CKD epidemiology equation, we can say 70, 80, 90. And so the preferred formula is CKD epidemiology. What are the risk factors included here for CKD progression? So it is stage 3 BA3. So A3 is a risk factor. It is red color. This means that it is associated with increased risk of progression. Age, old age, a risk factor. Male, risk factor. Diabetic, risk factor. Hypertension, risk factor. Obesity, risk factor. Stage 3B and albumin creatinine ratio in this range is a risk factor. Smoking, risk factor. Sleep disorder, risk factor. So this patient has many risk factors for CKD progression that we should educate him to and manage all these risk factors to reduce the rate of progression toward end-stage dialysis. What I'd like to end this presentation by advice to myself and all my colleagues: we should continue reading even we are drowning. This is one of the squares in one of the countries, and even if we are in the corona era, the corona is risky here. If the patient is chronic kidney disease, he is more prone to the very poor consequences of corona. So we should be careful about our patients, especially in this period of time. If you like to know all the details about corona and the kidney, you can see this video, but the language used in this video is mixed English and Arabic. At this point, I should say bye-bye and thank you very much. If you have any questions, please don't hesitate to contact me through my email. Thank you and goodbye. Have a nice day.